now as more and more segmental and non-anatomical wedge resections are being practiced, more so for segmental resections, it is very important to know the segments of the lung, the vascular supply to the segments, the bronchial supply to the segments, because to execute any segment that that knowledge is very, very important. So I'd like to thank you for taking up this topic. And I hope all the surgeons who are training in thoracic surgery will find it very useful. So please carry on, Dr. Thakur.
Thank you very much, sir. Am I visible? No, I don't think so, right?
Oh, you're not visible. No.
I think there should be some setting here. Start.
But I think you can go ahead with the presentation.
Okay. I don't know how to do it, but whatever my friend has put another camera in front of you. So without any further delay, sir, so I would request that today I will be confined to the bronchial anatomy only and its variations, because in one hour talk we cannot conclude everything. We cannot go through everything. So my outline would be for the today's session is only the bronchial anatomy and its variations. So if you allow further, maybe in the next webinars we can.
Hello, sir. Yes, interrupt a minute. Will you record the session? Start.
Yes, it's being recorded.
Okay. Thank you, sir.
Yes, yeah. So in the next sessions, we would like to come up with the webinars on the arterial anatomy and its variations, venous anatomy, and some surgical perspectives of segmentectomy. So today, let's start with the bronchial anatomy and its variations. So as we know that in 1932, Kramer defined first of all the bronchopulmonary segment. Thereafter, in 1943, Jackson and Hubbard gave the nomenclature, proper name nomenclature of the segmental bronchi. In 1949, a great anatomist, the Boyden, who has been quoted as of now also, right now also in several Western books and also Japanese or Chinese books, they quote the Boyden. He was a great anatomist, and he had given the detailed anatomy with its variations. In 1987, Collins has established the international classification for the bronchial segmentation. So this is the book which was published in 1955. This comes from the anatomist Boyden, and the book is named as Segmental Anatomy of the Lungs. And very interesting to note that he has done 9 years of work. This was done by the original author Boyden, dissected out, and he gave a very demonstrative, very illustrative pictures of all the lung specimens and all the normal anatomy and their variations. So in this picture is sketched by him in his book. So it's how it looked like at those days. In his book, the description of the pulmonary anatomy was given like this, and also a very good description. There is some certain modifications right now. If we go through the Japanese literature or the Chinese literature, there is some modification in the nomenclature only, but the rest of the things remain same. So Boyden was the anatomist which gave insight very deeply into the normal anatomy of the bronchus, the vessels, pulmonary artery and veins, and also defined the surface landmarks for each and every segment. So this is just in brief. He had defined also for the juniors, like right lung has the 3 lobes, the left lung has the 2 lobes, etc. So right now we are following the Jackson, Hubbard, or Collins classification. There is the UK based, and Yamashita, the Japanese nomenclature. The only difference here is that, like we see in the Western literature, what they do, they have defined this apical, posterior, anterior, etc. But in the Japanese Yamashita classification, they have nomenclature by B1 plus 2, B3, or B1, B2, etc. So this is how there is certain difference. This is again in the first picture in the left of the screen, we can see this is the description by the Jackson Hubbard. And the right side is the description by the Yamashita. So where we see the B1, B2, B3, etc., which is being defined in this picture. A very good for the juniors, for the residents. In the right side, we see the a palm seed makes another little palm. That is the acronym for all the segmental divisions in the right side. Similarly, for the left side is the Asia Alps. For A for apicoposterior, S for superior, etc. So this is not very, these are the basic things just to remember those stuff also. So coming to the point, in the book of Yamashita, they have said that they start the division from the order one. So we can see here the order one, it means we're contributing to, we're considering the lower bronchi. Then comes to the order two, here the order two, we can see these are the segmental bronchi, which we classify from level 1 or 1 to 10. So in the right side, we have got the 10 segmental bronchi, where in the left, we have got only 8 segmental bronchi. Then coming to the order 3, these are the subsegmental bronchi, which are further divided like A, B, C. Then we come to the order 4 with a subsegmental bronchi, where the Roman nomenclature is given, Roman numbers like 1, 2, 3, etc. Then order 5 even has been defined in the Japanese and Chinese literature, where alpha, beta, gamma are being given. Even further, order 6 division, where they give the X, Y, Z. So coming to an example, for example, right upper lobe bronchus, we take an example of the right upper lobe bronchus. We know this is the first order of the division. So it has got the 3 segments like B1, B2, and B3. So let's take one example of the B1, that's the apical segment of the right upper lobe. So it has got 2 subsegments, B1A and B1B. That this will come at the third order of the bronchial division. Then B1A can be further divided into B1A1 and B1A2. This is the fourth order of the division. Then coming further in the fifth order, we add A1 alpha or beta. Then even further, we come to the B1A1 alpha X, etc., etc. So I think this is beyond our scope of this lecture, because we never encountered this very subsegmental divisions. What we should be confined as of now, as the evidence has even supported, the segmental bronchi and also the subsegmental bronchi, that is of the interest for us. Why I'm emphasizing this is because if we go through the Western literature, even in the standard textbook of thoracic surgery, they have not mentioned very well about the segmental and subsegmental anatomy. They have not come up with the some variations in the artery or venous system of the even the bronchial system for the at the subsegmental level. So it will be great for us to remember and again recall those anatomic variations, even the normal anatomy, how we should do a proper segmentectomy. Because before, I think why it was not so popular before, because the standard practice was the lobectomy for any cancer. Whatever the size, we prefer to do the lobectomy. But right now, the Jacob trial and also the American CLGB trial has established the role of segmentectomy or any sublobar resection for a tumor less than 2 centimeters. Therefore, in the Western countries, I think maybe in your setup also, you might be seeing quite a lot early stages of the lung cancer. So in those cases, lobectomy has got the inferior oncological outcome in comparison to the sublobar resections. Therefore, it's very important for us and particularly for the thoracic surgeons to know the exact anatomical variation, exact anatomical surface landmarkings and divisions of the artery, veins, and the bronchus. These are the surface landmarks which have been shown by the Jackson Hubbard. And this is in detail. During surgery, we must have a precise concept of what should be the outer landmark or the surface landmark of the lung. For example, in the liver, we do not see any external landmark, where there is segment 2, where is the segment 3, etc. In the same way, for the lung also, we should keep in mind some impression that this should be the segment 1. For example, the right side, this is the apical segment. So we should have preliminary landmark, surface landmark. This lesion belongs to the segment 1. Similarly, for example, segment 3, it stands for the anterior segments. Therefore, if we flip the lung posterior, like here in another picture, we have the flip the lung posterior, we cannot visualize the segment 2 in the right side from the posterior side. So it means the name itself stands where the segment should be located. Definitely, this is the surface landmark, and what is very important for us surgeons, because we operate in the lateral position. So similarly, we should have a precise the impression, where are the segments, where the segments should be located. Like this, the S3 segment, this is the S1 segment, this is the S2 segment, etc. So similarly from the medial side, this is the bronchial division. I will not be going in detail because everybody should be knowing about. Only the thing is the right side has this right main bronchus is shorter than the left side. Generally, the right side bronchus is about 1.5 to 2 centimeters in length, where the left main bronchus is about 4 centimeters. That's the only difference. There are certain small variations in the segmental divisions also. But like in the right upper lobe, we have the B1, B2, and B3 subsegments, etc. The similar picture from the another look is the similar picture also. Now, what is very important, the subsegmental bronchial division as well. Most of us will be knowing about the segmental, the subsegmental division. I think it's also very important to know about them. So this picture, it has been taken from the book of Yamashita and Ikeda also. It has very clearly shown. Let's take an example only of the right upper lobe. This is the right upper lobe. This is the right main bronchus. This is the right upper lobe bronchus. Here is so here is it means the apical segmental bronchus. Now it has given the divisions, two divisions like B1A and B1B, which has further been divided into the subsegment also. But for us, it's very good to know that this is the, for example, this is the trachea, this is the right main bronchus, this is the right upper lobe bronchus. So right upper lobe bronchus will have the three subsegments like this. So let's suppose this is the B1 segmental bronchus. So it will have the B1A and B1B. B1A and B1B. So this much we should remember about the subsegmental divisions also. Similarly, not only the right upper lobe, not only the B1, every segmental bronchus has got its subsegment. Most of the segments have got only two subsegments, whether there are exceptions. Some of the segments have got three subsegments also. For example, if we take about the B6, B6 has got the A, B, and C. These three subsegments are located in the B6 bronchus. For example, if we draw a picture, this is the right side, this is the oblique fissure, this is the transverse fissure, horizontal fissure, and this is the segment 6. So in the segment 6, we have got the segment, subsegment A, which just stands for the apical, proper apical. Subsegment B, which stands for the lateral subsegment of the segment 6, and the medial A, B, C. So this assumption we should have in our brain while doing the surgery. So similarly, all of the things. So this is the 6th segment, or the B6 has got the 3 subsegments. In the left side, this B1 plus 2 has also got the 3 subsegments. That is B1 plus 2A, B1 plus 2B, B1 plus 2C. B3 segment in the left side also have got the 3 subsegment, and B6. Rest of the segments have got only lateral and medial, anterior and posterior, etc. So this is how we define. So coming to the point about the subsegmental division, I would say that in the right side, except the B6, all of the segments have got only 2 subsegments. B6 have got the 3 A, B, C. In the left side, if we talk about in the left side, B1 plus 2, B3 and B6, these segments have got the 3 subsegmental divisions. Rest of have got the only 2 subsegments. I think we can note that point, and we can remember all the nomenclature also. At the same point, for us surgeons, it's very important to correlate all the things with the CT scan finding. So this is a subsegmental pictorial diagram, very well seen, like in the right side, right upper lobe. We can see this picture drawn here. Like I will draw again. This is the oblique fissure. This is the horizontal fissure. So here is the segment 1. Here is the segment 3. S1, S2, and this is the S3. So in the S1, we divide into AB. Here also we divide into the AB. Here also we divide into the AB. So this is how we should have the impression of how many segments exist in the right side, how many subsegments exist in the right side, and similarly the left side. So this is the pictorial diagram of the right side of the lung, similar to the inferior surface. And this is of the left side. Left side upper lobe is a little bit more complicated, not only from the subsegmental division, but also from the surgical point of view. So which we'll talk about it later on. This is the same pictorial. Now, the one thing that's very important to know is in the Western literature, I don't think they have described it. There is a segment or bronchus called the star, segment star or B star. This is called sublobe, subsuperior bronchus, subsuperior segment. We know that, for example, this is the right lung. This is the oblique fissure. This is the horizontal fissure. This is the 6th segment. This is the 7th segment is here. 8th segment is here. 9th segment is here, and 10th segment. So this is 6th segment. This is the segment 10. Sometimes, not sometimes, I think 20% prevalence is not a small rate, I will say. So 20% of time we can visualize there is a subsegment or segment which is located between the 6th segment and segment 10. So this segment is called subsuperior segment or we call it the segmented star, SS star or BS star. So this also exists in many of the Western literature. They have not commented on this part. It's very important because sometimes we find more bronchi than we expect to find. If we're planning for the S6 segment, we can have S6 segmental bronchus and also the BS star segment also. We might be confused what we are dealing with. So here, sorry. So here we can see here in the same picture, this is the 6th segment as shown here. This is the 10th segment. And here is another segment, this one. This is called this SS star or sublobar segment. Sublobar segment. So there is one of the video I will show here. I'll share the screen. As shown in the CT scan picture, we can see in the CT scan picture, everything is shown here. So in the right side, now, this is the 6th segment, this one. And going down, we can visualize this part of the segment. This is the SS star segment. So we can visualize the CT scan as well. Now, there is certain things which have not been described in the Western literature again. Boyden, in his description, though he has dissected out only 50 lungs in the cadavers, but he has mentioned very well sometimes what happens that the bronchus is situated normally, but it arises from the abnormal side. For example, in this pictorial diagram, we assume that this is the trachea, this is the right main bronchus, this is the right upper lobe bronchus. Our assumption is the right upper lobe bronchus will give the B3, B1, and B2. But what happens, this B1 has got B1A and B1B. This also has got the B3 has also got the B3A and B3B. So this B3A, let's suppose this is the B3A, is not coming from the B3. It comes from the B1. So at that point, the picture will look like this. The bronchus is going to supplying the 3rd segment, but it is not arising from the B3 bronchus, but it is arising from the B1. So in this case, he describes it, he calls it BX. So in this case, this will be called BX3. It means the 3rd A segment is situated normally, but it is not arising from the B3 segmental bronchus, but it is arising from elsewhere. In particular case, it is arising from B1 segment. So here, given the classical nomenclature at BX, this is also not very familiar for many surgeons, I think. There are certain congenital tracheobronchial anomalies that we should remember. One of this is the cardiac bronchus. We can see here, this is the cardiac bronchus in CT scan well visualized. Sometimes we can find the tracheal bronchus. The less than 1% of the cases, we can find the tracheal bronchus. It has a different association also. I mean, different prevalence also. In the one option could be the apical segment. It means the B1 is totally replaced. It is totally arising from the trachea, whereas the upper lobe bronchus consists is only of the B2 and B3. In another part, this could be the supernumerary. It means there is the apical bronchus here in the normal position arising from the right upper lobe bronchus, but there is accessory. This is the tracheal bronchus, which is here situated. So this position can be this scenario can also be. This can also happen. Sometimes what happens, this upper lobe bronchus is completely arising as a tracheal bronchus. There is no upper lobe bronchus here. So this is totally replaced. So like in the peak, if we visualize the peak bronchus, it is typically like this. So there are certain views which you can visualize the bronchoscopy. I don't know, at your centers, I believe the bronchoscopy is performed by surgeon. Am I right, sir? Manish, at your center, do you perform the bronchoscopy yourself?
Yes, sir.
Yes, so that's very good. We also perform the bronchoscopy ourselves. So it's very good to correlate with the bronchoscopic finding and preoperatively knowing where is the bronchus, where is the subsegmental divisions, how it is coming is also very essential for us. So there is another variant of tracheobronchial anomalies, which is called isomerism. It is just mirror image. For example, this is the usual arrangement where you can see the upper lobe bronchus, the middle lobe bronchus, and the lower lobe bronchus.
You have to be there and sharp.
Paper from thoracic cancer in 2022, which shows that the 3D reconstruction is very essential. Like in paper, it has established. So this is one of the pictures how the software mimics establishes the 3D reconstruction. So very good, we can import the DICOM file in the CT, in the computer, and open in the mimic software, and you can derive all the bronchial anatomy. Not only the bronchial, we can see also the arterial and venous system as well. So this is a typical example. So in this case, we can very well visualize, for example, in this particular case, this is the right upper lobe bronchus. This is the B3. There should be this is the B1, this is the B3 and B2. So if some certain variations happen, then we can visualize in this software. It can clearly pick up what are the variations, is the normal anatomy or not. Similarly, the artery, venous system, everything can be seen in this software, but it is time consuming. We can even locate the tumor. For example, here in this software, the tumor is located here. So it can pinpoint, and also you can match with the intraoperative findings, so that lesion is there or not. When the lesion is impalpable, not palpable, then either you have to do the CT guided wire localization or other method accessories you have to apply, or you can just also take a guidance of the software, artificial intelligence. You can pinpoint where is the lesion located. So this is one of the examples of that one. So now let's come up with this brief background. Let's see what are the variations for the normal anatomy of the right upper lobe. So in the CT scan, we can see this is the right upper lobe. This is the right upper lobe bronchus we can see here. So here we can see we must be very familiar with the anatomy of the segments. So here just looks like the Mercedes-Benz sign in the right upper lobe. So these are the segmental bronchi. So the bronchoscope is going here, and you can see the segmental bronchi here. So here we should typically identify which segment is which one. So general description, if we go inside the right upper lobe bronchus, so this will be the right B1, this will be the right B2, and this will be right B3 in the right upper lobe bronchus. So, but this is not always true. Let's suppose in this is the C3 and C4 carina. So in this picture, we can see this the pattern of the bronchial division is B1 is one segmental bronchi, whereas B2 and B3 is the common. So here we can see the B2 and B3, there's only bifurcation of the right upper bronchus, not the trifurcation, not B1, B2, B3, but there is the B1 and there is the B2 and B3 as a common trunk, which can visualize here. Typically, we can here imagine, I mean, we have the imaginary option. We can see at the CT scan where we're visualizing the apical segmental bronchus, B1. Here we can match the same thing with the bronchoscopy. This is the B1. Similarly, B2, B3, here we can see this is the B3 and this is the B2. So similar matching we can do with the bronchoscopy is the B2 and is the B3. Similar things we can visualize, match the CT findings with the bronchoscopy findings. So coming to the branching pattern of the right upper lobe bronchus, we can see. Can you mute, please? Can you mute, please? Anyway, everyone, can you mute, please, from your side? It's taking trouble. Yeah. So we can see the branching pattern of the right upper lobe bronchus. So we think that is you. Can you mute it, please? So we see that this is the right superior lower bronchus or the upper lower bronchus. We think that this is the B1 plus B2 and B3. So we think this is the trifurcation variant, but actually in fact the bifurcation variant is more common. So we see this the simple bifurcation like B1 plus 2 B3 or B1 plus 3 B2, etc. It might happen. So what I'm talking about is again making a diagram. This is the trachea. There is the right main bronchus. This is the right upper lobe bronchus. This is the truncus intermediate. So our imagination is there should be always the B3, B1, and B2. But quite often this trifurcation variant is absent. Quite often, most of the time, this is the simple bifurcation variant. So where this the right upper lobe bronchus will have the B3, and this is the double variant. This will be a common trunk. Will have the B1 and B2. And this is the B3. So only two streams are coming from the right upper lobe bronchus. So this should be also we should be familiar with this anatomy during the segmentectomy because we try to cut it. This with the bisegmental, B1 and B2 will be gone. So this we should keep in mind. So this is the bifurcation by variant that is quite common. So now similarly, let's look in this pattern. So it has been reconstructed by the mimic software. We can see the lesion is located here. So now we did the reconstruction with the CT with the mimic software. This is the right upper lobe bronchus. Here we can see this is the B3 bronchus. But B3 bronchus, this is the B1B, and this is the B3 bronchus is going here. This is the B2 bronchus, where the proper B2 is going here, which will be dividing the B2A and B2B. And this B1A bronchus is here. So it means the B1 bronchus as such as a single stream is absent in this particular case. But B1 bronchus is consisting of the two subsegments, subsegmental bronchi, B1A, which is arising from B2 bronchus, B1B, which is arising from B3 bronchus. So in such cases, if we are planning for segmentectomy, we have to divide here, not here or here, because if we divide from here, a proportion of B2, significant proportion of the B2 will be gone. So we cannot divide it here. So we should keep in mind. So therefore, the nomenclature, the pattern will be in this particular case, this will be B1B, B3, comma, B1A, B2, and B3. Like this pattern we have to write, the split variance. Similarly, in this case also, we can see similarly. So S1 segment, one of the picture here, we can see the tumor is the CT scan located in the S1. This is the right upper lobe S1 segmentectomy will be done. So in particular case, as I said, that upper lobe bronchus in this particular case had the two bifurcation variant. B1 plus 2 is coming as a single trunk, and B3 common is the another trunk. And then the B1 plus 2 will be dividing into the B1 and B2. So this also we should keep in mind. So therefore, rationally we see by prevalence wise, the independent origin like B1, B2, B3 is present only in 40% of the case in the right upper lobe. Another variants, another rest of the variants, 60% are the anomalous variants. So we should keep in mind those variants as well. So like in this picture again, we can see here, this is the right B1 here. This is the B2 where we can see the subsegmental. B2A means the lateral, this one posterior, and B2B means the lateral part. So here we can see, we can just mimic the same thing with the bronchoscopic findings. There's the same way in the left side. So this is the one thing that's also not very, I never saw this this variant written in the Western textbook or the sales textbook textbook of chest. So this is the Boyden's triad. What is the past, what is the present, what is the future? It was published, described by Boyden in 1949. And after that, nobody was very careful about this Boyden's triad. So what happens in this Boyden triad? So this is a normal pattern of the right upper. This is the right upper lobe bronchus. Where see the right upper lobe bronchus is the B1. This one the B1. This is the B2, and then this is the B3. And then comes the middle lobe bronchus, and then comes the lower lobe bronchus. But in this Boyden triad, what happens? This is the B1, this is the B2, but the B3 is coming from the middle lobe bronchus. So it means this is the replaced B3. B3 is not coming at its own place, which the Boyden had says the BX, but actually it is the same thing. It is the placement is different. B3 is located coming not from the upper lobe bronchus, but it's coming from the middle lobe bronchus, like here. So the typical pictorial diagram would be like here. We can see this is the B1, this is the right upper lobe bronchus. B1 is B1A and B1B, B2A and B2B, but this is the middle lobe bronchus, which has got the B4 and B5. Along with that, it has got the B3 bronchus also, segmental bronchus also. So this is called the Boyden's triad, and we must be careful about this during the surgery. Why? Because B3 totally or partially shifted downwards. In such scenarios, we will not see any horizontal feature. It's fused totally. So it will be difficult to find out the horizontal feature. And this A3 artery, it will be totally interlobar type rather than arising from the superior trunk. Central vein is not typically between B2 B3, and V3 is also shifted downwards. So these things can be seen in the Boyden's triad, and we must have an assumption, an idea about this thing. Coming to the right middle lobe bronchus. So these things can be very well seen in the 3D reconstruction of the CT scan if we have one. So in the middle lobe bronchus, it's very easy to identify. This is the middle lobe bronchus, this one, B4 and B5, we can see in the CT scan. In this picture, it's very well seen. This is the B5, this is the B4. Even in the B4, we can see this one, B4A and B4B, very well seen. In the B5 also, you can see the B5A and B5B. So it's very clearly seen in the high definition CT scan. We can see all of this stuff. In the bronchoscopic picture also, we are working from the right side. So the lateral segmental bronchus, middle lobe bronchus will be located laterally and the medially medially. So there's the B4 and B5 is the bronchoscopic picture. In the same way it has been shown here also. Yeah. So in the middle lobe bronchus, What is the pattern? General pattern is the bifurcation, what we assume. So this is generally B4 and B5 and lateral and medial pattern. This is the most prevalent pattern. So the other patterns may happen, may exist also. So, but the prevalence of various variations of B4 and B5 is less important. Why? Because generally what we do in the middle lobectomy, we consider directly for the middle lobectomy rather than any segmentotomy of the middle lobe, because it doesn't have much more of functional capacity. So it's very easy to perform the middle lobectomy rather than any B4 or B5 segmentectomy. So this is of less of the importance as of now. Coming to the right lower lobe bronchus. So here in the right lower lobe CT scan, so at the ventricle level, we can identify this, the S7, S8, S9, and S10. So actually what happens in the CT scan, for the right side, it will move anti-clockwise. It means it is moving like this, S7, S8, S9, S10. But in the left side, it moves clockwise. Clockwise means like this one, 8, 9, 10. And the left side, in the CT scan picture, not in the bronchoscopy picture. So now let's move forward. Yeah, this is the same thing. In the bronchoscopy, where this is another pattern of the bronchoscopy. If we do the bronchoscopy, the right side, this is the medial-basal segmental bronchus, and 8, 9, 10 will be located like here. So it will go like in the clockwise direction, in the right side of the bronchial tree. So bronchoscopy, right B7, 10 will be clockwise. So let's see, this is the pictorial diagram which has been shown here. So, but what is very important is that not always we can visualize that like this will be the B8, B9, and B10. Like, let's see this bronchoscopic picture. This is the B7, it's fine. Here we can see this is the B8 because it's located anteriorly. So this is the B8. Now these two have the common trunk. So here inside we have to see this, the B9 is here and B10 is here. So what's the pattern in this particular case is that there is the B8, there is the B7, B8, and B9 and 10 have got the common trunk. That is usually a rule rather than exception. In most of the cases, this is the prevalent variant rather than the separate B8, 9, or 10. So this is what we can see here. So it's also this is one of the examples which we can see the B star, which I had talked about. So B6 bronchus is somewhere here. It has not been shown in this bronchoscopy picture. B10 is here. So in this between two, we can see another opening here. So this is particularly the B star or superior bronchus is located here. So in the CT scan, we can see this is the middle lobe bronchus is here, this one. This is the right lower lobe bronchus, and the sixth segment bronchus is this one, which we can see very clearly is dividing into lateral B6B and the medial B6C. So here in the CT scan, this is the B8, this is the B9, this is the B10. So this pictorial diagram also we should remember, we should know how to study the CT scan, particularly axial view is very important for us. Similarly, so what is the branching pattern of the lower lobe bronchus? What is the most important is in the sixth segmental bronchus, B6. This is the major branching pattern. B6A plus C come as a common trunk and B6B come as a separate trunk. B7 has the 7A and 7B. B8 comes as one stream and B9 plus 10 comes as a common trunk. So that is quite common. Coming to the left bronchus. So this is the bronchoscopic view, which we can visualize in the left bronchus. So it's even more complicated. The segmentation of the left bronchus of left lung is a bit complicated than the right side because the lingula is fused. So this is the left upper lobe. So in the left upper lobe, we can see here is the S1 plus 2 rather than S1 or S2. This is the S3, then the lingula S4 and S5. So we have to say this S1 plus 2 is further divided into A, B, and C. A is the proper apical, B is the posterior, and C is the lateral. So as shown in the lateral, this is the lateral view of the patient as we do the operation in the lateral view. So this is the S1 plus 2C, lateral. This is going posterior, therefore is the S1 plus 2B. This is the proper apical, so this is S1 plus 2A. So this also we should remember, this is the third segment or the anterior segment. It has got the lateral part S3A, the medial part S3B, and the superior part S3C. So this we should remember also during the segmental division of the left lower lobe, left lung. So let's come to the left upper lower bronchus. So this is what I said before, S1 plus 2, S3, S4, and S5. So this is the typical diagram. Here we can see during the bronchoscopy, generally what happens, this is the trachea, this is the carina, this is the left upper lobe bronchus, this is the left lower lobe bronchus. Upper lobe bronchus will have the superior division and inferior division. Superior division is further divided into apico-posterior and anterior. So this will be B1 plus 2. This will be B3. And this is the inferior division, which will be further divided into the B4 and B5. So this is the typical pattern that we theoretically should understand during the bronchoscopy of the left upper lobe bronchus. But it is not always true. The divisions may not be similar in each and every cases. So this is the left B1 plus 2 and the B3, yes, shown in this pictorial diagram. They're the same pattern. In the 3, we have got the 3A, as I showed before, 3B and 3C. So in this particular bronchoscopy view, we can see this is the lateral part, therefore the 3A, is the medial part is the 3B. But but actually this description was given from the textbook, but I found that they have by mistake put it as 3 and 3B. This should be the 3 and this should be 3B. So I have corrected this. Maybe there was some printing mistake. This is the book of Pallav Shah of the bronchoscopy. So now let's come to the left upper lobe bronchus, the superior B1-5. The commonest pattern is the bifurcation pattern, where the B1 plus 2 and 3 comes as one trunk that we call the superior division, and B4 plus 5 comes another trunk that we call the inferior division. And these are the patterns, various patterns that can exist during the bronchoscopy, or even we can see in the particular CT 3D reconstruction. So this is the branching pattern. If we talk about the B1-3, the two branches are common. One comes the B1 plus 2 and B3. That's most common in the 46% of the cases. B1 plus 2, generally, as I said, these are three subsegments, B1 plus 2, A, B, and C, but A plus B are joined together, and C is a separate branch in most of the scenarios. B3, as in most of the scenarios, 3A comes as a separate, and B plus C are joined together. Coming the left lower lobe. So this is the left lower lobe in the CT scan. These are the pictorial diagrams which we see during the bronchoscopy. So this is the sixth segment as shown in the left side of the lung. This is the basal segment. In the sixth segment, we have got, and even in the left side of the sixth segment, we have got 6A, 6B, and 6C. A stands for the apical, most apical. If something is here, the apical. B stands for the lateral, this one. And C stands for the medial here. Sorry, A is seen here, is the apical one. So B and C, that can be seen here. Yes, like this one. Yes. Moving further ahead, we can see this the most anterior part in the left pulmonary division. So this will be the eighth segment. Eighth segment has the lateral part 8A as shown here. This is the medial part 8B. Now this is the 9 and 10 are fused together. This common trunk. This is the 9. This is the 10. This is the posterior most part. So it will go like this: 8, 9, 10 in the left side. So the same pattern here we can see here. B7 is generally absent because in the left side, the 7 and 8 are fused, and we call it simply as the B8 or S8 segment. So the commonest pattern for the B6 division is B6C and A plus B are together in the sixth segment of the bronchus. Similarly, there are various patterns I can see here. In the basal trunk, generally B8 is a separate bronchus, and 9 plus 10 are fused together. It means, what I mean to say, there's the trachea and the straw, there's the right main bronchus, there's the right upper lobe bronchus, there's the truncus intermedius, middle lobe, and lower lobe. Lower lobe has the 6 segmental bronchi. This is the basal trunk. So in the basal trunk, we'll have the 8, 9, and 10. I'm drawing from the right side, but the similar with the 9 and 10 will be fused together so as to make the 9 plus 10. This will have to mirror because I have drawn from the right side. I'm talking about the left side of the bronchial tree. So the branching pattern of the left lower lobe is 6 segments, generally comes as 6A plus B subsegment are joined together, and C segment is coming as separate. Similarly, B8, 10, 8 is a separate, and 9 plus 10 are joined together. So there was one study very well done in the 2022. They have shown the 3D reconstruction image of the CT bronchography and angiography. They found that bifurcated type is 99.4%. And this left upper lobe is highly variable. They said that left upper lobe is the most variable. I mean, and the variation exists more often than normal anatomy. So in this pictorial diagram, we can see very clearly, as shown here, This is in the right side. This is the right, sorry. This is in the left side. This should be the left. This is the left side. Sorry, I'm sorry. This is the left side, the lateral position. This is the left main bronchus. This is the upper lobe bronchus. This is the lower lobe bronchus. In the upper lobe bronchus, we see the B1 plus 2, 3 is a common trunk arising first. Then from there, it will be the B3 segment and B1 plus 2 is going like this. And this is the lingula bronchus, B4 and B5. Similar various patterns may happen here. B1 plus 2 as a separate entity, B3 is here, and B4 and B5 and B3 are joined together as shown this here. B1 is coming as one trunk, and B3 and B4 plus 5 and the lingula are coming as one trunk. And then B3 will be further dividing like this in this picture. So there are various variations may exist as shown in this picture. So according to them, this B4, B5 only entity will happen in 77.4% of the cases. There are various variations as shown in this picture. So they concluded, so there are various variations that happen usually in the left upper lobe segment, left upper lobe of the lung. So there's one of the picture recently we encountered doing surgery. We are doing the left upper lobectomy. So what we found during our dissection here, we found there is something going downwards. We thought previously this is the upper lobe bronchus, but what happened with later on recognized this is the lingular bronchus. This one, this is what is going downwards was the what is going downwards was the B8 going to the anterior segment. So we should keep patience and we should dissect properly. This was the lingular bronchus, and this one which is going downwards. This was the B8 bronchus. It means the B8 bronchus is arising from the left upper lobe bronchus rather than from the lower lobe bronchus. So this sort of the anomalous variations may happen. We should be very cautious about this. So in this particular case, this one which we have ligate is the lingular bronchus. This one which I'm trying now to dissect it out. This one is the B3 bronchus, and B1 plus 2 located here. So it means the B8 bronchus is rising from the upper lobe bronchus. That we found recently, about 3 months ago, we had operated on this patient. So my take-home message for the first part of my webinar will be that we have to have the precise knowledge of segments and subsegments. Bronchial anatomical variations are not uncommon, and bronchoscopy and 3D, CT, bronchography, and angiography is very much essential for that. So I would like to thank you very much. If you have any questions or comments, Mistry sir, I'm very looking forward to you. If you have any suggestions, any comments, please.
So excellent presentation. But the anatomy, as everyone realizes, is very complex, and it will take some time to digest. But excellent presentation. I think everybody is going to gain quite a bit from your webinar, and we are looking forward to subsequent webinars on vessels and veins and arteries.
Thank you,
So
sir.
what you can also put up on the webinar is the software which you are using for delineation of the bronchi and the vessels, both the pulmonary artery segments and the pulmonary vein branches.
Yeah, that's true. Thank you. That's true. Manish?
Yes, sir.
Am I audible?
Yes, you are audible, sir.
So,
Sir, echo is there. Now it's okay. Now it's okay. No, it's still echo.
Can you hear?
Hello, sir. Can you hear us?
am I audible?
Yes.
Manish, am I audible?
Yes, you are audible, sir.
4
432 627 471 432
4 4 4 3 2.
I know 432 sir. 627
27.
715.
लो, बंद हो गया मतलब फिर से पासवर्ड.
Hello, Manish.
Yes, yes, you can.
Yeah. So am I audible now, Manish?
Yes, yes.
Yeah, so sir has made a very important point regarding the software that we have been using. So actually, in fact, this software that I'm talking about, the Mimics, it takes a lot of time. It's very time consuming. We started with that software Mimics. We have got this software. So reconstruct one patient reconstruction takes about 1.5 or 2 hours. So I think this is very cumbersome. So I think if radiologists could do this job, that's great. I don't know, maybe in your setup they can do it. So we're very much fighting hard to find out those software. We have got the Mimics, but it's very difficult. We cannot have so much of the time for the Mimic software, sir. But we have been using the Mimic software. What you have been using, sir, in your practice?
No, we are not using any software. We are relying only on the CT scan information that we have now.
Yes, sir.
But we would like to incorporate this software, and like you said, it is best done by the radiologist rather than surgeons.
Yes, sir. That's very important point, sir.
Also requires high quality.
High quality CT scan, I believe is very much important. So I believe in your centers should be very good. In our centers, quite open because we get the patients from outside our centers, so they might not have a good quality of CT scan. And quite often they come with the CT films, it will be very difficult for us. So we always request the patient to bring the DICOM files so that we can study the CT films at our center. That's also a very good point. I think in your center also many patients will be bringing only the CT films. It will be very difficult for you to define the segmental and subsegmental anatomy. So what I found, sir, in our center, we are not a very good center like yours, though it is a national hospital, national cancer hospital in our country, and is the largest cancer hospital in our country. But we are still fighting with the proper infrastructure. Like we have got the 64 slice CT scan, but radiologist part is missing. I mean, they are not providing a very good quality of CT film, so not each and every patient will be given the DICOM files. So that's what we are facing the problems, but we have now requested them, please provide the DICOM files for each and every patient so that we can work out ourselves. That is one point. The second thing, what I want to tell my juniors, I mean, Manish is my junior, I think the rest of the colleagues are also the juniors, that I would suggest that during surgery, what I recommend is bronchoscopy should be done by yourself. If it is central lesion, if it's not central lesion, at least you can identify what variations can exist. That is very better picked up by the bronchoscopy, like the combined with the split bronchial divisions, etc. You can very well define the bronchoscopy. And very important thing is that during surgery, you should have in your mind, if the lesion is palpable, that's very good. If the lesion is not palpable, that brings that is a trouble for you, because in our setup, our radiologists do not insert the CT guided hook wire. We do not have the radial bronchoscope like we were in the Hyderabad. They were the bronchoscopists were doing the radial bronchoscopy, instilling the ICG inside the very peripheral area. So that's not possible in our center. So what we do, we have an imaginary mind. So this is located in this segment, even if the lesion is not palpable. So with that point, at least you can do a proper segmentectomy. Let's suppose the lesion is located in the S8 segment, which we can very well define by the CT film. Then we can, even if the lesion is not palpable, we can take out the S8 segment. That will be very good, I think.
Yeah, any other questions anybody else has, maybe you can address that also.
Is there any question in the chat box? I think there are none, sir. I don't see any question in the chat box, sir.
So this is just the beginning, but as you know, it becomes, we have more and more webinars. I think we'll be more organized, and I'm sure you will have a lot of queries and questions.
Yes, sir.
Thank you very much for your webinar, and we look forward to the second and the third webinar.
Thank you very much, sir, for your presence. Valuable insight, sir. Hope to meet you again, sir.
Right.
Yeah.
Thank you.
Sir. Thank you, sir.
Bye.
Bye-bye.